the doctors here. Sir, I'll enter the room. I'll wash my hands. I'll take permission from the. I'll greet the examiner. I'll take permission from the mother and from the child to examine the child. I'll ask Sarah to show her hands. I look for pallor, pallor and clubbing.
No pallor.
Is there clubbing?
No clubbing.
After that, I'll check the palms for any palmar erythema.
No palmar erythema.
I'll count the pulse for 10 seconds. How's the pulse? And I'll check the volume and
pulse and right radial is 86. It is normal in volume, regular rhythm.
I'll check for the radial pulse on the other side also simultaneously. Is there any
left radial pulse is absent?
Okay. Then I will examine the head. How's the head size and shape, sir? Okay. Okay. After that, I'll ask Sarah to lower her lower eyelid to look for pallor. Is there any pallor?
No pallor. No pallor.
I will look for jaundice in the upper sclera. Is there any jaundice? Any conjunctival? Any conjunctival congestion?
No congestion.
Then I will ask Sarah to open her mouth, and I will look for dental hygiene, overcrowding, and high arch palate.
Oh, high arch palate. No problem.
Okay. After that, I will look at the neck. I can see that she is having webbing of neck. Is it right, sir? I'll actually look from the back of the child. Is there any webbing of neck?
Webbing noted.
Webbing, sir? Pardon me?
Yes, webbing is present.
Webbing is present. Okay. After that, I will inspect the chest. I can see that the nipples are wide apart. There is there any shielded chest, sir? How's the shape of the chest?
No shielded chest.
I can see that the nipples are widely placed. Is there any scar? Any deformity, sir?
Where you are looking for scar? No scar anteriorly.
No scar anteriorly. Okay. I will ask Sarah to lift both her hands, and I will see for any scar in the axillary region.
There is a scar on the left thoracotomy.
There's a
left thoracotomy scar on the left side. Left thoracotomy scar.
Left thoracotomy scar. Okay. After that, I will place both my hands on the chest, and I will look for the apex beat.
Okay. Critical impulse is seen on the left side, fifth intercostal space, lateral to midlateral line.
Okay. After that, I will check for I will check the 4 areas for any thrill in the 4 areas. Is there any thrill in 4 areas?
No thrill.
Mitral.
No thrill.
Mitral. No thrill. Okay. After that, I will do. I will check for the left parasternal heave. Is there any left parasternal heave?
No heave.
Okay.
No parasternal heave.
Okay. After that, I will check for the murmur in 4 areas: mitral, tricuspid, pulmonary, and aortic area. Is there any murmur? No murmur. Okay. After that, I will check the legs for any edema. Is there any edema?
No edema in the legs.
No edema in the legs. Okay. After that, I will check the back for the webbing of the neck and low hairline. Is there any low hairline?
No hairline present. Webbing of neck present.
Webbing of neck. Okay. Then after that, I will check for murmur in the interscapular area.
Yeah, no murmur.
No murmur. I'll check for any crepitations in the basal area.
No basic crepitation.
Okay. Okay. I would like to. Is there any scoliosis, sir? Backside scoliosis?
No scoliosis.
Okay. I would like to finish my examination by checking the saturation, blood pressure in all four limbs. I would like to check for radiofemoral delay, and I would like to plot our height and weight on growth centiles. Sir, before that,
will you summarize your findings?
Today I had the opportunity to examine 11-year-old Sarah, who is well looking. There is no distress. On examination, she has a webbing of neck, and she has a left thoracotomy scar, and left thoracotomy scar. So my differential diagnosis: she is having acyanotic congenital heart disease. And most probably Turner syndrome, sir.
Okay. What sort of acyanotic heart disease? Can you give some more definitions? Can you refine your diagnosis?
It could be coarctation of aorta, sir. Most probably Turner syndrome. Probably
okay, what is the cause of this? Like you, did you notice the pulse in the left side? What is your finding?
Pulse is
left radial pulse. Left radial pulse.
Left radial pulse. Sir, I didn't ask for the character and volume of the pulse.
Okay. If left radial pulse is absent in this scenario, what is your
left side? Some most probably coarctation of aorta, sir.
Okay. So there is a radial pulse is absent on the left side. So how would you justify your diagnosis with this scar?
It could be BT shunt, sir.
Okay. So how would you like to investigate, Sarah?
BT shunt. Okay. Investigation. I would like to take. I would like to check the saturations. I would like to take a chest X-ray. I would like to take ECG. I would like to involve cardiologist. And
what findings do you expect in chest X-ray if in case there is an uncorrected congenital heart disease? Okay, what findings is expected in ECG for this study?
I don't know.
Okay, so how would you like to manage, Sarah?
Sir, I would like to. My team would include a multidisciplinary team. Would include a consultant pediatrician, cardiologist, genetics, genetics doctor, sir, and I would like to.
Considering your differential of coarctation of aorta, what is the residue? What are the complications you're expecting in this site?
What are the complications of coarctation of aorta?
Yeah, in this site. She has a scar, probably serious. Getting a surgery for it. So, what are the complications you're expecting?
Complications: short stature, cardiac complication, coarctation of aorta. Then,
okay. What are the complications you're expecting post surgery in a coarctation of aorta?
Complication of surgery.
Yeah, post-surgery.
Post-surgery, infection. I don't know, sir.
Any particular advice you want to give for Sarah?
Advice, good nutrition, dental care, avoid tattooing, and physical activity as told by the cardiologist.
Okay, Doctor. Thank you. Bye now.
Yes.
Next, Doctor, notes open. What is your feedback? How we can improve here?
Yes, sir. There are lots of points that I missed. Even the initial 4Ds I missed. The distress dimension.
Let us not panic as we enter. This is bound to happen. Like once we enter, the time is very short. So we are eagerly waiting to get the findings, right? So try to at least act that we are maintaining our cool and just go with the approach. Okay, whether you are getting the diagnosis or not, maintain your calmness and go with the approach. Okay, so as you enter, did you wash your hands?
Yes, sir. I wash my hands.
Okay.
I took permission. I introduced myself, but I didn't do the 4Ds.
So start with the
Initial
4Ds. Okay. So in case,
yes.
okay, so leave it up. If it is at a runner syndrome, what are the thing you're expecting in your general inspection? Apart from the dysmorphism, I noted the web neck and other things.
Uh, upstanding of eyes.
Others, please mute
Like that,
yourself.
I make it 400. I have to pay my spoon back.
Dr. Azil, can you mute yourself? Azil. Yes.
Upstanding of eyes. Low posterior hairline.
Overall, apart from the dysmorphism of the turners, you are expecting short stature, right?
Yes, a short stature. Yes.
So that is like if you do the 4Ds, you can tell she looks apparently short. However, I would like to plot her on centile short, right?
Yes, sir.
So in the general examination, so we can make all the findings of her or whatever it is. If it is pretty obvious to you, then go for it. Okay. Many times we will not be able to see the classical web neck, but a female with short stature. Okay, if you are having the findings come to something like a cooperation, then think it could be a turnus, right? So we may not have the classical webbing and other things. Okay, so just keep it in your mind. Now, if at all, if you are expecting something finding in the neck in a turner's case, like if you want to go from hand to face and then to neck, what are we expecting in the neck in case an adolescent turner?
Neck, webbing of neck.
The being in the posterior, anteriorly you are expecting a thyroid swelling. Okay, there can be hypothyroidism or Hashimoto. Autoimmune thyroid is common in them. So just look in the anterior aspect also.
Okay.
Now, when you are going to summarize again, so going into the cardiovascular system, once you go from the hands for the clubbing, the things, markers of endocarditis, pallor, other things, and into the face, oral cavity, look at the neck anteriorly as well as posteriorly. Okay, then come to the chest, go for the inspection first. Okay, so try to find your findings and inspection where is the apical impulse. Okay? Just give it a running from whether you're able to see or not. Okay, and give a 360-degree inspection. Okay, do not panic in the exams. So see the anterior, posterior, as well as the lateral aspect. And you did that. You tried to get the scar. Now, what could be the cause of left pulse absent, left radial?
It could be because of the BT shunt, sir.
Okay. So BT shunt is not done here. Okay. So here we do either it should be a dilatation or it should be a flap repair. Okay, or a end-to-end anesthesia. Okay. So if you take a subclavian flap, then you have the left subclavian absent generally.
Okay.
And most of the times the cooperation is post-rectal. So what are the complications you're expecting? In a case of provocation of aorta, it is operated. Again, there can be a reprovocation.
Restenosis, yes.
Okay. It is possible. So that, like if there's a question on how you're going to operate, you will be doing a dilatation. Okay. Again, you can do a resurgery or you can do a dilatation. And hypertension can persist. Okay. In spite of surgery, the hypertension can persist. Okay. Now, what about the apical impulse left to the causa space lateral to mid-clavicular line? What does it say?
Pardon me, sir. What is it?
Your apical impulse is lateral to left mid-clavicular line, right? Full space. It's lateral to
Yes,
mid-clavicular line, is it not? So, what does it say? Shows that there is a left ventricular hypertrophy.
Left ventricular hypertrophy.
So just X-ray, you in case of an untreated heart disease, you will look for notching, particularly in image around 10 mm, you have this findings. ECG, you will get left ventricular hypertrophy, right?
Okay.
And advice, you are right. So you have generic advice, okay? We used to discuss this. So have generic advice in place for cardiovascular solution to avoid ear piercing, tattooing, have a good dental hygiene, dental follow-up, and exercise as per cardiology, okay? As per the pressure gradients, they will advise what they can do. And management here, there are specific things. So here we have an, if they have a residual coarctation or if there is a restenosis happening, then management for that part. And management of Turner syndrome per se. Turner syndrome per se, it is hormone supplementation, growth hormone therapy, and the estrogen. These things will fall in place, and the genetic counseling, psychological support, and other things. And evaluation of other organ development, like kidneys and other things. Kidney, thyroid. So these should be things. Any other questions regarding this case? Feedback from others? Open to discussion. So in a cardiovascular case, if you don't have any murmur and if you have pulse absence, think of provocation of aorta. So just to have a quick view on the scars. If you have a scar on the right side, okay, generally the scars for the lung, scars for the esophagus, okay, so they are better approached from the right side. So like lobectomy, all these are more often on the right side. Okay, if you have a right left infraclavicular swelling or a scar, think of a pacemaker thing. And a median scar, it's meant for an open heart surgery. Okay. So you have a scar on the right side. It could be a scar for the BT stent, or it could be a scar for the lung, or it could be a scar for the esophagus. Right side, right posterolateral or right axial, something like that. Okay. Scar on the left axilla could be left BT stent, and posterolateral scar could be a lateral peritoneal scar. Okay. A scar on just below the left side cavity could be a pacemaker scar, and a medial sternal scar for complex heart disease. Right.
So in this case, what was the scar meant for?
Left peritoneal scar.
Yeah, it was for repair of coarctation of aorta.
Coarctation of aorta, yeah.
Okay.
Okay. So, Dr. Fatima, are you here?
Yes.
Okay. Can I take this session?
Yes.
Okay. So, as you enter the room, I introduce you, child Arun. He is 7 years male. Examine Sabari.
Okay. I wash my hands and I introduce myself. My name is Dr. Fatima. This is my mark sheet. I introduce myself to Arun. Hi, Arun. How are you?
Yeah, Arun is just smiling at you.
Okay. So I'm going to check whether he has any dysmorphic features. Okay. Dimensions.
So, he looks a bit short for his age. Okay.
Okay.
And build is appropriate.
Okay. Devices attached.
No devices.
Is in distress.
Not in distress.
Okay. So I will just take his hands and I'll look for the palmar erythema or clubbing. Is there any clubbing?
No clubbing.
Okay. So I will just see, I can see multiple cannulation marks. So I'll just go up and I look at his face. I will tell him to pull down his lower eyelid to see if there is a pallor or jaundice.
There is a pallor. Jaundice not.
Okay. Okay, and I can see that there is a maxillary thing. Okay, and what about the tooth? I can see there is overcrowding. And is there any, can he open his mouth? I want to see if there is any cyanosis.
No sinuses.
Okay, so Arun, can I see your abdomen, tummy? Can you please raise your shirt as for the exposure? Okay, so first I will. Okay, so I will see his tummy from the side and from the end of the bed to see if there is any abnormal pulsation or any scars,
No stars, no pulsations.
any the distension of the abdomen is there.
Abdomen looks distended.
Pardon?
Upper part. Abdomen looks distended, mainly in the upper part.
I didn't hear you, sir.
Abdomen is distended in the upper part.
Upper part. Okay. Okay. So I would just go near him, and then what about the shape umbilicus?
Umbilicus looks very good. Push down.
Oh, push down. Okay. So I will warm my hands, and I will just go. I will start doing the superficial palpation of the abdomen. And does he have any pain anywhere? I'll look at his face to see if he has any pain.
No pain.
Okay, so I'll go for the superficial deep palpation again, and if there is any, I look at his face for any pain.
No pain.
Okay, and that I will try to palpate the liver from the lower side, and I'll try to feel the lower border of the liver, and I'll tell him to take a breath, take breath, and so that he can feel the lower border. Is the lower border? Can I
This
feel
liver
it?
is palpable 6 centimeters below the right costal margin.
Okay, so I will start percussing from the second intercostal space in the midclaviculary line downwards to find the dullness. Where is it?
So you get it in the fifth space.
Okay, so I will just measure the span of the liver. What is the span of the liver?
The span is 10 centimeters.
10 centimeters. All right. So I will just palpate the left lobe of the liver by palpating from the umbilicus. How many centimeter? How many fingers down the costal margin?
It's not audible.
Okay, so I will start percussing for the palpation of the spleen from the I'll go from diagonally from the right iliac fossa towards the spleen area. Can I feel the spleen? Is the spleen palpable?
Spleen is palpable just above the umbilicus.
Just above the umbilicus. So what is the span?
It's around 8 centimeters.
Okay. Okay. So I will try to palpate the kidneys. Is the kidneys palatable?
No, no palatable.
Okay. Okay, I would like to complete my examination by checking for the lymph nodes, and also in the to check for the genitalia, and also look for the back for any scoliosis or any scars, and check his vitals.
Okay, no scars in the back. Genitalia
Okay, and lymph
looks
nodes
okay. No
and
lymph nodes.
any lymph any edema in the lower limbs.
No edema.
Okay, I forgot to ask about there is any caput medusa or anything on the tummy?
No.
Yeah, okay. So I will thank Arun, and I'll say to dress him up, and I will finish my examination.
Okay, can you summarize your findings?
So
Positive
I have
findings.
examined, I have examined 7-year-old Arun, who looks well, not in distress, small for his age, having a maxillary hyperplasia, overcrowding of the tooth, and frontal bossing, with multiple cannulation marks, and he had jaundice. I forgot. And on examination of the abdomen, I could find that there was splenomegaly, and liver was palpable, just palpable, span of 10 centimeters. And there is no peripheral edema or lymphadenopathy, no scars.
Okay. So what is your differentials?
So I put it as chronic hemolytic anemia for differential diagnosis.
Okay. So how would you like to investigate?
So I would like to do first of all review his file and see his previous records, and to do a complete abdominal examination, and also to see his if there is any transfusions done, whether diagnosis is already made. If already made, I will not go ahead with the electrophoresis. Otherwise, I'll go for electrophoresis. Also CBC to check for the HB levels and MCHC and all that. And I would do um, mm, a liver function test. I will do mm, a thyroid function test. I will do blood sugar levels, all and
Okay.
bleeding
What for
profile.
thyroid function test?
Pardon?
What for thyroid function test?
That is to see the complication of the disease as such, if there is after any iron overload or anything, if there is any endocrinopathy.
Okay. Fine. So considering this child belonging to an Asian ancestry, like what is your differential among the hemolytic anemia?
Asian thalassemia.
Okay. So what findings you are expecting in a peripheral smear for this child?
Thalassemia, we can the HB. You mean to say that in the electrophoresis? You mean
The peripheral smear.
peripheral smear? Okay. So there will be mm, uh, uh, hypochromic anemia. Hypochromic
Okay.
microcytic anemia. Yeah.
Okay. Okay. So how would you like to manage this child?
So I would like to manage the child with the help of multidisciplinary team, and I would do a hypertransfusion regime to maintain the HP of 10. And I'll give for the iron overload, we can do chelation therapy, and mm, uh, yeah, that will be the main main supporting treatment, and the definitive treatment would be bone marrow transplant.
Okay. Is there anything you would like to do before starting him on chelation therapy?
I would like to check his renal functions. I would like try to see that is renal functions will be checked, and um, that renal function will be checked. And
Okay.
also visual disturbances are there also, if there is a, because of the chelation. So maybe we can check the vision also.
Okay. So what complications are you expecting in this child?
So this is mainly the complication of the disease and complication of the treatment. Complication of the treatment would include the endocrinopathies, as I said before. Thyroid, can be diabetes, can be cardiac cirrhosis, um, uh, and delayed puberty, delayed and papillary necrosis, blurring of the vision, night blindness, and all that. And of the disease as such is the growth, delay in the growth, delayed puberty, and short stature.
Okay. What advice you want to give to this child?
So I would tell him to avoid crowded places. I would give him a bracelet, and to screen, because he is having yeah, I think these things would be there, and to maintain the growth and nutrition.
Okay, Doctor. Thank you.
Thank you.
Yes, it's open for discussion. Inside of Fatima, would you like to add something here now? No, you're off the grid.
You want me to add?
Is there anything you want to add here?
No, sir. You may.
No. Okay, fine. So I think you almost hit every point like whatever I had. Only thing is maybe you could add genetic counseling here, okay, of the family members. If only I want to say one point, just add genetic counseling because you have a thalassemia, then definitely genetic role there. Okay.
Okay. Okay.
Apart from that, nothing else I could add. Like you picked up all the findings. So only thing is in peripheral smear, like you will see this target cells, nucleated RBCs, target cells, apart
Yeah.
from microcytic hyperchromic RBCs.
Okay.
Complication of
Okay.
therapy, you did start well. Like you can divide it as a complication of the disease. So complication of disease
Yeah.
could be growth failure,
Yeah.
extramedullary hematopoiesis causing abdomegaly, osteoporosis, sometimes gallbladder
Yeah.
calculi,
Fractures, bone
and
fractures, and all that.
fractures. Yeah, osteoporosis fractures. And the
Yeah.
complication of treatment, it could be because of the blood RBC. Okay. And that could be again divided into infection complication. Majority of it is right now it is screened. Hepatitis B, C,
Yeah.
all those things. And
Yeah.
other thing is iron overload because of the frequent transmission. Again, iron
Okay.
overload can affect from pituitary, thyroid, heart, liver,
Yeah.
diabetes,
Panhypopituitarism and all that can
penis,
happen.
everything. Okay.
Yeah.
And again, complication of chelation therapy. Again, that could affect your liver. Transaminase should be monitored, and monitoring of vision and hearing should be done. Okay.
Yeah.
So you did have an approach, so it should give you full marks for this stage. Okay, good. Just include genetic counseling alone, it completes your overall
Thank you.
summary. Yes. Others, any feedback with this session? And if you have a thalassemia child, I think hemolytic anemia, go for it. Say thalassemia. Okay. So this is
Yeah.
very classical case. If you're taking the exam in
Okay.
India, then likely to have thalassemia and demonstration because they are readily available. They come monthly for follow-up for transfusions. So
Okay.
likely to be a case. Okay. Okay. Any doubts here? Can this be extrahepatic portal vein? Again, anemia and this hepatomegaly. Okay, there you have a large spleen with no signs of liver cell failure. Here you have a hemolytic phasis with anemia with a tinge of jaundice. And just want to give you a thing that jaundice may not be very obvious in the room setting. And particularly in hemolytic anemia, they may have just a mild hemolytic jaundice, which may be not be very apparent. Okay? So if you have the phasis pallor, go for it. Okay, don't just think that they should have a very typical jaundice. Okay. So anybody else want to try the next station? Any volunteers? We have one or two more cases. Somebody can try. It's open now. Dr. India?
Yes.
Okay. Others, kindly mute yourself. Okay. So this is an other station. And I introduce you, child Sophia. She's 8 years. Just examine her. Do a general examination and proceed in accordance with your findings.
I'll start.
Yeah.
I'll wash my hands. I'll go inside. I'll introduce I'm Dr. Vidya, one of the candidates for the exam. Hello, Sophia. And I'll also greet her accompanying person. So may I examine you, Sophia? Is it okay?
So Sophia mom says okay, and Sophia is smiling at you.
Okay. So Sophia, could you just show me your hands? So is there any pallor? Anything? No. I can see some rash. Okay. I'll just see if there is any nail cyanosis or any clubbing.
No cyanosis, no clubbing.
Okay. Then I can see some rash. Is it blanchable rash or any tenderness over the rash?
Not blanchable, no tenderness.
Okay. Okay. Now
You find child is a bit scratching and reddish.
child is scratching it. Okay. So okay. Then I'll go up. Is there any Anything in the arms? Any rash? The extent of the rash, is it extending up to
It
the
is
arms?
there up to elbows.
Hello, sir. Didn't get it, sir.
It is up to elbows, as you see in the picture.
It's up to the elbows. Okay. Okay. Then I'll just go. Is there any anomalies in the head? Any microcephaly? Anything? Okay.
No microcephaly.
It's over the neck also. Okay. Okay. So in the eyes, is there any features of any allergy, like any allergy shyness or anything?
No.
No. Is there any pallor?
No pallor.
Okay. Any jaundice?
No jaundice.
Okay. Any nasal polyps or any pale mucosa? Anything?
No.
Okay. Then ears, any ear discharge?
No ear discharge.
Okay. Then in the neck also, I can see the same type. Is this also itchy rash?
You're not supposed to ask question.
No. Okay. Okay. Yeah. Then chest, is there any similar type of rash in the chest or anything? Any lymph nodes which I can palpate in the neck?
No lymph nodes in the neck. No rash in the chest.
Okay. Okay. Then lower limb, any such rashes? Anything
She has a similar rash, like one in the forearms and the elbow, behind the knees.
behind the knees? Was there any rash in the elbow joint, in the cubital fossa? Sir? It was, yeah. Okay. Okay. Okay, no lymph nodes, no inguinal lymph nodes or no axillary lymph nodes was also not that.
No lymph nodes.
Okay, I'll just take my strength and do a respiratory to look if there is any wheezing or anything.
And there are scattered V's across, which is bilaterally.
Okay, then okay, yeah. Okay, this rash, I suppose it's an urticarial type of rash. Is it, sir? I can't clearly see.
Okay, we can summarize at the end. We want to examine any other part of the body.
Can I get her dimensions?
Yeah, she looks moderately built.
Okay.
The stature is moderate.
Is there any devices attached?
No devices.
Okay. Okay. She isn't in any distress.
She is not in distress.
Okay. Her mentation, she's smiling. Everything is fine.
Yes.
Okay. Okay.
So can you summarize your findings?
So today I examined 8-year-old girl who was moderately built. However, I would like to plot her on appropriate growth centers. She, on general examination, I could find that she had generalized. I mean, she had an an urticarial type of rash, which was mainly distributed over the forearm, including the cubital fossa, and also behind the neck, and on system examination, I could also find that she had a scattered bees in her lung fields. I would like to inspect her back for any similar rashes.
So what sort of rash is this, according to you?
I felt it more as a maculopapular. I couldn't clearly make it out. So I found it as a more of a macular type of rash, but since it was the distribution and taking in account the VZ part,
So if it's a papular rash, if you are examining and if it's a papular rash, What is your differential again?
So I would check if it's a it wasn't blanchable also. So I would check the distribution over the back and the buttocks, and or the joints also, if any joint was involved, and then probably HSP should have also brought into.
Okay. Any other differentials you want to add here?
Taking it as a papilla rash, you mean, sir?
Okay. It's a papilla rash.
Papilla rash. A vasculitis, any type of vasculitic rash. Then if it's a
So
yeah, then allergy. I mean, if it's an urticaria, then allergy rashes would also be.
So what sort of allergy rash you want to think here?
Atopic rashes, atopic dermatitis.
Okay. So any other differentials you want to give here?
Because it also had a wheeze, I was more into the atopic type of rash.
Okay. Okay. Would you like to think eczema? Okay, fine. So how would you like to diagnose your finding? If it is atopia or eczema, whatever it is?
So basically the history is more important than to ask if it's an itchy type of rash and how it evolved, how it was in the whether it was right from the early childhood. And
Okay, so you mean to say it's a clinical diagnosis,
no,
right?
and also it's a clinical diagnosis, plus I would also go for the eosinophil count and the IgE levels. Yeah.
Okay. So is there an indication to take a swab in case in this child?
Yes, if there is any features of any secondary infection or any herpetic secondary infection, then
Okay.
swab it. Yeah.
So how would you like to manage this child considering this as an eczema?
Okay. So considering it as an eczema, I would first involve the multidisciplinary team involving the consultant. Then if there is no secondary infection and the child is okay, I wouldn't admit the child. Then the dermatologist would also be brought into the picture. Then I would tell the mother about what the illness is, and liberal application of emollients is more important. Then how it should be applied along the hairline. The nails should be cut short. Then if the child is scratching too much, then antihistamines can be given. Then during flares, steroid creams can be tried. It should be given initially up to 2 weeks. It can be given. Then also do take care if there is any secondary antibiotic, secondary bacterial infections. Tell them how it should be checked at home. Then also do counsel them about the possible food allergies and yeah.
Okay, doctor, thank you. So yes, now it's open. So sometimes when you get a skin station, like just do not like, just stop your examination. Okay, just try to. So examination of skin includes examination of skin, examination of hair, examination of nails, examination of mucosa. Whether these are required or not, if you are just having a skin findings, try to touch upon all these findings. Say nails are normal, mucosa is normal. This is a rash limited only in the skin and only in the flexus. It is multiple erythematous, papillary type of rash. Okay. On inspection, it is multiple erythematous rash, and I could see the rash is accentuated in the flexures. Okay, in the knees as well as in the elbow flexures. Okay, bilateral, it's symmetrical, and it's a papillary type of rash. It's not tender, but I could see some exploration marks here and there. Okay. And if there is any findings you want to look at the nose for this child?
Nasal polyps and the pale nasal mucosa.
Nasal polyp and
Pale nasal mucosa would be more pale.
pale. Okay.
Allergic.
I think allergic salute.
Salute.
Yeah, allergic
Yes.
salute kind of it. So otherwise, the diagnosis is clinical. Okay. And if at all you want to take a swab, either it could be for a viral infection, herpes, eczema herpeticum, or if you're having something crusting lesions, again, it could be a bacterial pathogenous infection possible. I think management, I think you complete you avoidance of allergens, exacerbations, parental education. Okay. And nail care, can we include it here? Nail care, occlusive dressings. This could be the management plan. Okay. Now, regarding emollients, if at all there's a question asked, advice, how will you advise a parent regarding use of emollients? Like first we have to wash the hands, okay? And you use a specific spoon to take the emollient from the main bottle. Do not put the hand directly into the bottle to avoid infection, and apply emollient in a unidirectional way, okay? You should not scratch the skin again because there is this itch scratch cycle going on. And if there's an exaggeration, if you're applying topical steroids, you should have some time gap between emollients, probably some 30 minutes to 1 hour timings should be maintained between emollients and the topical steroids. And topical steroids should be used for the shortest duration, okay? Because they can cause skin thinning. And the second line therapies can include other immunosuppression like calcium inhibitors, tacrolimus could be used. And antibiotics mainly for secondary impetigo here, and antivirals for eczema herpeticum. Differentials here you could include contact dermatitis. Okay, so that could also be brought here. And if this child has a syndromic facies, then think of this other complex. If there's a differential you want to offer, the examiner says if this child has a syndromic facies and other things of recurrent infections, think of immunodeficiency syndromes, primary immunodeficiency syndrome, which can coexist with eczema, hyper IgE, viscous allergies. This could be possible. Okay. Any other common differential eczema? Sometimes psoriasis also may have itching and like
Papular
sometimes.
urticaria.
Pardon? Urticaria.
Papular urticaria.
Yeah. So urticaria is still possible. Again, urticaria, the lesions will disappear. Okay, unless it's going to be chronic. Psoriasis, you can tell. Inverse psoriasis, they may happen on the flexus. Okay, so again, it's a type of psoriasis which can happen, and sometimes they may also have itching, and they may also have sort of plaque-like lesion. And patient on treatment, sometimes the plaque may not be very that much very obvious. It may look as a papular. In all these patients who are coming to the exams, they'll be on treatment. So let's not have the typical patients in our mind in the photo in our books. So the lesions will be here and there plus or minus. If it is coinciding with other findings, just go for it. Okay. And you could go to differential. It could be differential of psoriasis also in case if you have only a skin case, then think of these few differentials like eczema, urticaria, psoriasis. These are common differentials, okay, for the exams. Any doubts here?
So you said the child has wheeze, so the respiratory system could be like examined in brief.
Yeah, you see, that is one thing. If you have the main station as skin and you have findings in other station, just go for the auscultation only. Do not go for the other findings like inspection palpation there. Okay. The same scenario applies to all other stations. You have a cardiovascular station, just auscultate the base of the lungs. Okay. And you have some other station. Say, for example, you have a syndrome child or you have an MPS child. You want to just look at the heart, just listen to the heart. Sometimes the examiner will give you a clue, listen to the heart. It means just do auscultation. Okay. Listen to the lung base. Just auscultate. Do not do a full examination. Right? Okay. There is one more case. If somebody's interested, we can go for it for today. So take home point is examination of dermatology includes skin, hair, nails, mucosa. Whether it's normal or abnormal, you have to comment upon all these things. Again, here inspection and palpation, whether it's a raised lesion, whether it's a papule, plaque, or nodule. So go for it. Okay. Whether there is any findings like any Koblenz phenomena is there like that, you can comment. Okay. And whether there is any excoriation marks, you can comment. Blanching, if it's a rash, yes. See, the rash of HSP is more on the extensor aspect, not on the flexus, and more on the lower limbs. Okay. And vasculitic rash, typically it could be purpura or petechiae vascular type of lesions, and a vasculitic rash may be painful. Okay, they can come either way, but HSP is in the lower limb. Usually, vasculitis rash, they are not itchy. They are more of pain rather than itchy. Psoriasis, typically it's on the extensor aspect of the elbows and the knees. Okay, that is a classical location, but sometimes inverse psoriasis can come on the flexors. Psoriasis, usually it's a non-itchy. It's a little sort of plaque, but sometimes they may have itching. Okay, any volunteers for the next case?
Sir, can I take it?
It's Dr. Geeta, right?
Yes, sir.
Okay, fine. What that some of the common triggers, like if you want to give a patient advice. See, when it comes to eczema sort of thing, it is more about patient education, patient advice. Okay, so avoiding too much of any strong soaps or any like thing, something like which will cause dry skin. Okay, avoiding too much of hot water. Lukewarm water is recommended. Not too much hot, not too much cold. Okay, and avoid too much of drying. And contact allergies, whatever it is, whether it could be a new dress or something, a strong soap, all these could have exacerbate things. Ambient temperature, avoiding food allergy, known allergies, all these things are the advice recommended. Okay. So, Dr. Gita, you entered the station. I introduce you, child Mary, 8 years. Okay. She has some fatigue and some sort of discomfort after her school work. So, examine her MSK station, musculoskeletal system. Yes.
Okay. I have entered the station. I have washed my hands. I have greeted Mary. Um, uh, can I know how
Yeah,
whether
yes. Proceed. This is an MSK session. Proceed with your examination.
okay. Can I what can I know about the position of the patient?
Yeah, she is sitting in the couch.
Sir, actually, I'm new to this. That's why I was not.
Pardon?
Sorry, sir. Actually, I didn't. MSK, I never tried it.
Okay. That's another good time. Okay, you can try now.
What can I know? What are the main what are the main complaints Mary has got come to you?
So, like Mary says, she has a difficulty in writing the school works and she has difficulty in buttoning her shirts.
Okay.
And she
Is
feels
there,
tired and pain after coming from school.
okay. Does she have any tiredness during walking?
So you want Mary to walk now? She's walking. Gait looks normal.
I can say some no, sorry, sir. Maybe I can't do
Okay,
this.
no issues. Okay, anybody else wants to try this station?
Can I try?
Dr. Rohim? Yeah. Dr. Vishan Pankaj Kumar, yes. We'll start from the beginning. Yeah.
So I'll enter the room. I'll wash my hand. I'll introduce myself. My name is Dr. Pankaj. I work at the first hospital. So today I've been asked to examine Mary. So is that okay? I'm asking mother and Mary
Yeah,
both.
mother says okay. Yeah, Mary is nodding.
Okay, so okay, so I just want to know about whether any dysmorphic feature in Mary.
No dysmorphism.
Okay. Okay. Any distress?
She is not in distress.
Any devices nearby or any support?
No
near?
devices.
Okay, and what about her anthropometry, like height, weight, and
Yeah, she looks a bit obese. Height is fairly okay. Looks average.
okay. So then I would like to what is Mary doing at the moment?
Yeah, she is sitting in the couch.
She's sitting in the. So I'll ask Mary if she can stand for me.
Yeah, she's standing.
So while standing, I will see from head to toe whether there is any obvious finding that I can see.
So which part of the body you're looking at?
In the leg, like flat foot or any bowing of the leg or okay. Okay, so I can see that there are some rashes over joints, knee joint, both knee joint, and also down over shin. Right.
Okay, yes, please proceed. Yes.
Okay. Okay. So then I would like to look from the back. I'll look the back of Mary, the spine. Is there any abnormality in the spine?
No.
I would like to gently palpate the spine. Is there any tenderness?
No tenderness.
Okay. I would like to ask her to walk. Can she walk for me?
Yeah, she's walking.
I'll support her. Okay. So is there any
She's
abnormal
walking.
gait?
No abnormal gait.
Okay. So can she walk on tiptoe?
Yeah, she's walking on tiptoe.
Can she walk on heel?
Yeah, she's walking on heel.
Okay, and on her lateral aspect of foot?
On her
Lateral aspect of foot.
lateral aspect of foot.
Yeah.
Okay.
Walking.
Okay, she is able to walk.
Okay. Okay. So then I would like to ask her to do some maneuvers. Like I would like to ask her to do hands like this.
Okay. So she is doing that.
Okay. Okay. Then I would like to ask her to make a star for me like this.
Yeah, she's showing a star.
Okay. Can she do like this? Any problem in
Yeah,
doing
she's
this?
making a circle. She's making a circle.
Can she count like this?
Yeah, she's able to touch.
Okay. Okay. Then can she do like this
Yeah, she's able to do the prayer sign.
and like this?
Yeah, reverse prayer. Yes, she's able to do.
Okay. And I would like to gently palpate the metacarpophalangeal joints like this.
Yes,
Is there any
she's
tenderness?
no obvious tenderness.
Okay. Then I would like to ask her to raise her hand like this and look into the ceiling. Is she able to do it?
She's able to do it. She's able to do it.
Okay. Then I would like to ask her to do like this. Can she do this?
Yeah, she's doing it.
Okay. Then I would like to ask her to do like this and like this.
She's doing it.
Sorry, like this
Yes, she's doing it.
and like this.
Yes, she is following you.
Okay. I would like to ask her to put 3 fingers into the mouth. Is there? Is she able to do that?
Yeah, she's able to do it.
Okay. Then I would like to come. I would like to ask her to get into the couch, so that in supine position I want to examine.
Yeah, she is getting onto the couch.
Okay. Then I would from leg end. I would like to see whether there is any leg length discrepancy, apparent leg length discrepancy.
No discrepancies.
Okay. Then I
You
would like to
notice
palpate.
this scar on the legs.
Yeah, those. Yeah. Then I would like to palpate. I would like to see about the patellar tap. I would like to do patellar tap. Is there any effusion, evidence of effusion on both sides?
No, patellar
One
tap
by
is
one.
negative. There is no fluid. No.
Okay. Okay. Then I would like to check internal, external rotation. I would like to flex at hip joint and also 90 degree at the knee joint, and like to do
Yeah, you feel
internal,
the joint are
external
a
rotation.
bit more mobile.
More. Okay. Okay. So I would like to ask. Uh, uh, okay. Okay. So I would like to ask again to stand and to touch the ground. Can she touch the ground with her
She's
palm?
touching the ground. She's touching the ground.
With the palm?
Yeah, yeah, she is keeping the palms like this on the floor.
Okay. Okay. Then I would like to ask her to do like this again to see this carrying angle. I mean,
Yeah,
this
carrying angle is fine.
fine. Okay. And hyperextension at this joint, both joints, like
Looks normal.
hyperextension looks normal.
Elbow
Okay.
looks normal.
Okay. And hyperextension at the knee joint.
Looks normal.
Normal. Okay. Mm, right. Okay. And can she do like this? That can touch.
Yeah,
Like
she
this?
is touching. Yeah, she's able to do it.
Both sides. Okay.
Yes.
Both sides. And if I ask her to like do like this, it's more than 90 degree.
Yeah, she's able to do it. More than 90 degree. Yes, time up. Can you summarize your findings?
Yeah, so today I examined 8-year-old Harry, and on examination I found that there is no problem with her gait or spine. There is no problem with spine. Upper limb details is apparently normal, and on lower limb details I can see that there is some skin rashes over both the knee joint and also over the shin area. And I found that her detail score is around 6, around 6. So joints are hypermobile, feet have hypermobility.
Okay, so what is your differential based on your findings for today?
My
Because this child
differential,
has some difficulty in, like she has some pain and discomfort after coming from schools, and she has difficulty in buttoning her shirts. You should ask screening questions.
yeah, I forgot to ask about all those screening questions.
Okay, so if that is the answer, like what is the differentials from your examination findings?
My differential for my differential would be like it may be a case of hypermobility, and also maybe like juvenile idiopathic arthritis,
Okay.
and as well as psoriatic arthritis, considering those
Okay.
tests.
Okay. So, okay, considering your differential of hypermobility, how would you like to manage this child?
So regarding hypermobility, basically treatment is could be multidisciplinary team approach where the therapist, occupational therapist, and uh, yeah, some exercise regimen and some advices like uh, not to do hyper those those activities. So those activities. Not to do those activities and graded exercises and advices like standing while standing, bending, slightly bending of knee joint, and then uh, uh, and some if needed some orthosis may be required to support the foot and joints.
Okay. So, any specific advice you want to give for this child?
Specific advice like
Considering her
advice.
anthropometry.
Yeah, weight reduction. Yeah, weight reduction.
Okay, Doctor. Thank you.
Should be advised.
Yes. Okay. So, basically, this is a case of hypermobility. Okay. So, these are like scars over the areas of trauma. So, these are like thin-looking scars. Could be a case of an Ehlers-Danlos syndrome. Okay. So, with these scars and hypermobility, you can think of Ehlers-Danlos syndrome. So, I think the management approach is like it's good. Like you are able to like pinpoint what are the points I had, like physiotherapy, occupational therapy. I think avoiding overweight, those are fine. Just correlate, put the findings together. If you are having a case who has a joint pain and you do not have an obvious finding on PGALs, then your differentials is here and there. If the child is having any swelling but there is no pain and everything is fine, then either it could be just a bony swelling causing a deformity like a rickets or skeletal dysplasia. Again, no swelling anywhere, but the child looks tall. Whether it could be a morphnoid child and having hypermobility. Okay, and if it's a normal such a child with this set of skin scars here and there, then think of hypermobility with Ehlers-Danlos syndrome. Sometimes nothing is there, only hypermobility is still possible. Okay.
Skin elasticity
So,
should be seen, no, sir?
yes, yes. So if you have a scar like this, then go for the Gorlin sign. Okay, you can look at the skin folds in the forearm or in the arms. Okay, you can establish the Gorlin sign. Just want to, for the sake of, I think this is glad the study group. I just want you to share one. Maybe this could help you. Okay. So if you have a child who is having only joint pain, okay, could be juvenile arthritis. If it is a monoarthritis, could be any hemophilia or it could be rheumatic leukemia. Definitely, these are not on the exams. So it should have juvenile arthritis, mono or poly. If you have a joint with the skin, it could be psoriatic arthritis, part of JAA, or it could be a lupus, or it could be an maybe even a dermatomyositis. Okay, there you have an arthritis with the skin findings. Along with that, in myositis, you will have a Goversen positivity. If you have only swelling, no pain, okay, no skin lesions, only deformity and swelling, think of rickets and skeletal dysplasias possible. If there's a short stature, again, strongly think of rickets and skeletal dysplasias. No pain, no swelling. Normal stature, it could be a plain hypermobility. Tall stature, it could be a Marfan's. Okay. And you have some deformities here and there. It looks syndromic. Think of any syndromic child like mucoparasacrosis or any skeletal dysplasias. You can just give a syndromic child. Okay? That's enough. So basically, this whatever case we saw right now is ehlers-Danlos. Okay, you have a skin and you have no obvious joint swelling, but you have sort of some joint discomfort that is more often finding because of hypermobility. No obvious arthritis. With this peppery scars, there could be a EDS. If this child is obese, then the primary treatment is weight reduction here, okay? Because that is going to add more mechanical stress here. So the treatment is mostly, advice is mostly encouraging these patients to have physical activity, like low impact exercises. If you are asked about advices, just tell the word low impact exercise, which means like swimming, these things are low impact exercise. Avoiding any exercise which you do in the gym, like lifting weights and stretching the joint. Just because they're able to stretch it, they should not stretch it again and again. So have to have breaks in between the exercise. Need to have regular breaks, not continuous exercise. And weight reduction is the cornerstone to avoid adding more mechanical stress. And use of sprints. If this child has difficulty in writing, then again you could have a wide grip, the one in the picture, just to show. Make you to remember these things. There are options available for EDS patients like this pencil grip and this finger sprint, ring sprint. There are multiple options which they can use to avoid this overstretching of the joints and make them comfortable. And do not do any repetitive exercise and do not do overextension because they're able to do it. They should not keep on doing it. So these are the things. And if it is an apparently tall looking child, if they're asking one system you want to examine, go for the cardiovascular system. So that could be a Marfanoid or Marfan syndrome. So examination of the cardiovascular system. And mind you, both are autosomal dominant. So like genetic evaluation, again, evaluation of other family members, they could be brought here. And more of occupational therapist role here to how they can make their quality of life better, activities of daily living, how they could give inputs. So those will be the line of management. No drug is required for this condition. Okay. Any doubts here? You read PGALs well, sir. Like you are able to do the PGALs. Only thing is, do not forget the screening question. If it's an MSK station,
Yeah.
you get this. If you have the screening questions, and if the child says, "I have difficulty in walking," then focus on the PGALs of the lower limb. If you have an apparent swelling in the knee, go for the local examination of joint first. Look, feel, move, approach. Compare the disease joint. If it's a right knee, compare the left knee. And next, do one joint above and below. Then the PGALs of the lower limb. That should be the sequence. If there is no obvious thing on inspection, then go for the PGALs of the lower limb. Right? If you do PGALs of the lower limb, again, upper limb, no findings, then think of whether it could be a simple skeletal dysplasia. If there is obvious swelling is there, no pain, but just simple some swelling is there, it could be recurrent skeletal dysplasia. Again, no swelling is also there. It could be hypermobility. If it is tall, think of Marfanoid. If there's some scars like this, think of EDS. So when you think it's hypermobility, go and do the Baton's course. Do not just waste time because the time is very short. So you establish your diagnosis first, and then you can think of other things. Right? And PGALs, try to practice it so that you will tell the child how to do it. Rather than instructing the child, you will show the child. Do like this. Hardly it will take 2 minutes. But only if we are fluent in the technique, then the child will follow it. Most of the times in the exams, the child will be doing the same for multiple. The child will be trained actually. So after some few candidates have passed through the session, then they'll be actually more than cooperative to you. Okay. So like if you are fluent to the thing, then it will be like going very smoothly, or else you will stuck with the technique. It will be very much obvious. If you are not done PGALs once, it will be very pretty obvious to the examiner that this is not practiced routinely. Okay. So any doubts here? And this foot, what about this foot? Like if you happen to see a foot like this, it's more of an
I think it may be
everted foot, flat foot.
Flat foot, yeah. It's like that.
Yeah, flat foot. Okay, so more of a pointed foot, or you can tell everted foot, so flat foot. Yes, best planners, yes. So shall we close for today? Any doubts with this session, or we'll close?
Thank you, sir.
No doubt, it was very good, sir.
Thank you.
Thank you for the session.
Okay then. See you all. Bye. Good night.
Okay. Thank you.